This is the microphone, right? Okay. I'll try to stay close so you can hear, because I know sometimes I've had a hard time. Can you guys hear me okay? Wonderful. Okay. I like humor. Humor is very important. And I'm a nurse practitioner / therapist, and it's interesting because I've worked with children for years as a clinical specialist in child development, and then became a nurse practitioner. And then I went back later to get a master's in social work because I really felt like I needed to have more expertise in knowing how to work with the parents and the families, because you parents are the first, most important people in your children's lives, and I certainly recognize that. And I know that dealing with aggression can be incredibly challenging. So I hope that today's session answers some of the questions that you have, and we should have plenty of time at the end to answer questions and deal with any specific situations that you have to deal with. If at any time during the presentation you have questions, just raise your hand and I'll try to pick up on that and answer your questions. I do work presently as a nurse practitioner and therapist at a private outpatient psychiatric practice in Indianapolis, Indiana. Formerly worked at our tertiary children's hospital in Indianapolis. Have worked for years, since 1978, with children who are now adults with various handicapping conditions. I like to use the acronym CALM when I think about, and the other thing too, that the slides for this are on the Whova app, so you don't have to write everything down, so you can find these slides on there as well. But I think of the acronym CALM, and with the C, it's staying in control of your own emotions. I use the acronym OFFA, or the statement. I remind people often to stay on shore. When your loved one, whoever you're interacting with, is in this stormy sea and they're raging, don't jump in with them. Just stay calm. You got to figure out what are some of the lifelines you can throw out to them to try to reel them back in and help them calm down. So you have to be in control of your own emotions to be able to do that. The other thing is the next is the A, is being aware. What are contributing factors? What are things that might be causing this person to be aggressive and to act out in aggressive ways? And the next is the L, loving. You have to be you tone it down. You more non-critical, supportive. Because if you get angry and become real, too firm in how you approach, that can oftentimes escalate the situation. And the other is being mindful, staying in the present moment. It's not a good time ever when someone's losing it and they're upset to get in your mind about oh my gosh, this is what always happens, or oh my God, what's going to happen, and just stay present in the moment and just, again, staying mindful. And there are mindful exercises that might help you be able to do that. And when I think about what aggression is, it's the act or action of attacking without provocation. I mean, sometimes they come out of the blue, these periods of aggression. Other times you can see that, we're heading that direction. And the best thing you can do with aggression, if at all possible, is to prevent it. If you can pick up on real early cues, nonverbal cues oftentimes, maybe just a change in the facial expression, a turning away, just more subtle cues versus even verbalizations that there's a period of upset that's coming on. And then the other is forceful and sometimes overly assertive pursuit of one's aims and interests. And I think, when I think about, in particular, some of the rigidity and the fixations that people who have DCC have, they'll get focused on what it is they want. And actually, there's an article written, it's more like for bipolar, but it's the, what is it? It'll come to me later. But it's how once they get this, it's the irrepressible agenda. And that's what I think sometimes you see. They have an agenda. It's on their agenda. And none of you are going to be able to get in the way of stopping them. So that's where hopefully some of the things we'll talk about today will help you be able to kind of reframe things and be able to kind of back up a little bit and offset the rage. Causes of aggression. There's anxiety, fear. Oftentimes we see that when I think in particular about some of the stuff even like that Dr. Brown talked about in his talk with DCC is the difficulty predicting outcomes. So anxiety is pretty common in most individuals who have DCC or an ACC. If their routine is disrupted, if there's a change at all, a change that they weren't expecting, a new person, a new thing that they have to do. The hard part, too, is like you want to give them warning, but the others, you don't want to give them too much warning. Because if you give them too much warning, that's what they'll fixate on, and they want to do it now. So a lot of it, so much of it's timing. Another cause of aggression is anger. And oftentimes that anger, it can be underneath like a mood. There may be some anxiety. There may be some depression. There may be an old situation that's related to the present situation, and they're mad about that, but it's hard for you to know that because they don't necessarily verbalize it. And then certainly any type of a brain dysfunction where the brain just doesn't communicate. I think, too, think of processing speed. It's like oftentimes we'll say something, we want something, and we want it to be done now, and they're maybe just processing what it is we want to be done, and we're getting frustrated, and they can pick up on that. That person can pick up on that, and then they start reacting in a frustrated, aggressive way. Confusion is another, and then just frustration. And this can all certainly be related to one another as well. So if you can look at ways to decrease anxiety, ways are, what are things that cause your loved one to get angry? What are their underlying brain processes and how do those work? Having predictability, and then again, if there's frustration, kind of backing down. And again, some of the approaches we'll talk about here shortly will address maybe a way to do that. When I think about, I did some of this yesterday in my talk on medications, but lower brain functioning is really more people who are more vegetative. People can live with lower brain functioning, but they don't necessarily feel or think when just their lower brain is functioning. All information from the outside world through our senses enters our brain through the middle brain. And there are structures in particular that are important in that. And the amygdala is one. And I always think of it's like a sensor. And when information comes into the brain and has any sensory or emotional information attached to it, the amygdala goes on. Okay? And then typically what happens is the amygdala goes off, and then the middle brain releases information up to the higher brain processes, the cognitive, the thinking brain, the frontal cortex, the cingulate cortex, up in the, again, I always think, too, of the corpus callosum as it has many, important functions in the brain. But I think of it, too, as in some ways insulating the emotional brain from the thinking brain. And when there's not a corpus callosum, I think there's less insulation, if you will. So there's more tendency to react quick versus kind of slowing down and being able to process. So again, what we typically want to work on is how to get that middle brain calm so that information that goes up to the higher brain is accurate in terms of the interpretation and appropriate in terms of the response. So this is again, if we break it down, information comes into the brain from the environment, and we get signals from the ears, the eyes, our different senses, and then some of that information goes to the amygdala, and then the amygdala responds to it pretty rapidly based on the emotions of the information. If the brain is calm, the information, it goes up, and the thinking brain processes it, interprets, figures out, problem solves. In a stressed brain, the amygdala gets stuck on, and it doesn't allow the information to get to the higher brain. Or if it's stuck on, even I always think of a rheostat switch where you can brighten the lights. If it's on full, that the amygdala is stuck on, it's like a steel door that blocks information from getting up to the thinking brain. If it's on middle, it alters the perception of what gets up. So, and I think I've got here on the next slide, here's an example of how things can be interpreted differently based on amygdala function. If a person's brain is calm and someone frowns, they may interpret as, well, that person's in a bad mood. If they're stressed, maybe they're anxious, angry, it's that person doesn't like me. You see how the interpretation is different. If someone bumps, and I use these examples from kids I've worked with over the years and teens in schools. If someone like bumps into a person is, oh, I must be standing too close, I need to back up. I've had other situations where a person kind of got bumped into and like, he just hit me, I'm going to hit him back. So they kind of go into an attack mode. So see, the interpretation is very different. So again, that's why we want to work on helping middle brain function a little better, and we have to do a lot of the outside work because their brain isn't, especially with stress. There's actually Ross Brown, who has done has a really good book I'll talk about shortly, just says when we are frustrated or angry, we lose probably 20 IQ points. So, you think about if you already have some cognitive limitations and you're frustrated, you lose even more. And it doesn't just pertain to the people who have DCC. We're the same way. I mean, I don't know how many of you have ever thought about, wow, I wish I would not have responded that way, because we tend to, regress, if you will. The other is if they're confused about, if a person's confused about what to do on a task or chore, ask for help. If a brain is stressed and they don't know what to do, it's this is stupid, you're stupid, I can't do this. So they just get stuck and go into meltdown mode. So again, this is ideal if we had brains, because when our brain is calm, typically again we can take in things, process it reasonably, and life is pretty good. We can handle what comes. If you look at if people are depressed, and again that's oftentimes happen, and a brain is sad, that lowers the ability and lowers the threshold of the brain to be able to tolerate any stress. If a brain is angry, not calm, again, that's what's the focus. I hate this, leave me alone, And I've had, patients who will say, I'm going to kill you, and they get so angry and rageful, and then the schools will say, well, they can't come back to school because they threatened to kill, and I'm like, I'm not worried about them killing somebody, but it's the language that they use sometimes when they're really angry. I've had kids, too, who've done drawings, and they're like pretty scary drawings, and it's their release, because oftentimes when you're angry, you can't access the words, and so sometimes drawing is a way people get it out. The other is if a person's anxious, there's so much worry that they can't take in and process information. And I think anxiety is very, very common that we see with DCC. And then the inattentive brain, people who have ADD are focused on other things, and again, especially if they miss a piece of information, they make a mistake, or sometimes they can be pretty darn happy, but they're not doing what they're supposed to do, and then other people get upset with them, and then the aggression comes out of them picking up on other people being upset with them. And then if there's autism, and again, that's fairly common comorbidity with DCC, and their ability to process information can be oftentimes quite impaired and hyper-focused on what it is that they want to focus on. And then we have some patients who have all of these conditions at one time. And I think in particular if that person has a bipolar disorder. So what we do then is look at, okay, what do we have to aim at first to kind of get the brain calmed down? So again, the big thing is we want to have brain as calm as it can be. Let me go through here. This is an older, and it's from it's an old slide, but it just shows like PET scans that show up involving language, and there's two different areas in the middle cerebrum when a person hears words or speaks. And then again, you look to if the brain to come up with the right thoughts, to be able to come up with words, if their information is stuck in the middle brain, this part of their brain is not working well, so they're not going to be able to necessarily talk or process information accurately. This is an approach that was suggested, and I found it to be very helpful by Deb Lipsky, and I don't know if any of you have ever heard her speak before. She's from, I think she's from the East Coast, but she was diagnosed with lots of different things until she was in her 40s, and she was finally diagnosed with autism, high-functioning autism. But it's called the SCARED approach, and we will recommend using this approach for schools when I have kids who have difficulty with aggression at school. So I use the reference I listed the reference at the bottom of the slide. The thing is a safe. First of all, on the SCARED is making sure that the child or the teen adult feels safe, that there's no threats. Maintaining a calm voice and a calm environment. So there, again, that's where any extra noise that's in the environment needs to, and voice volume even needs to be lowered rather than increased. Affirmation, letting that person, when they're upset, know that you're aware they're upset. I mean, you have to engage with them so they know you are recognizing their distress and you're there to help them through that. So it's affirming. And again, a whole routine and having is oftentimes a lot of repetition in a very calm voice, and there's just a very not threatening in any measure. Any threat, like coming at a person, grabbing a person, oftentimes it's going to further escalate the behavior. And then being empathic to try to let them know you're aware, they're upset. Sometimes, if you want to lower, if you know ahead of time, what are things that calm them as a rule? But sometimes if they're in the middle of an upset and starting to get really aggressive and you talk, it's too much input. Sometimes just a quiet presence is just in a quiet, calming, just again, not even necessarily saying anything, can be very helpful in kind of thwarting the outburst and settling the meltdown. The other then is having, I develop a plan, but now ahead of time, what in the past do you know has helped in terms of calming the person down when they're feeling really aggressive or really angry or agitated. But oftentimes you can't even initiate that until you get the initial upset calm down. Sometimes I know like music, a rhyme of some type to try to get them locked in or engaged on something else rather than what it is that they're upset with can be helpful. I would say, too, like I think of Allison in particular, she likes to grab. So you don't want anyone who's like grab hair in particular. You don't want to be close enough that they can grab because once it starts, it's hard to stop it. So the thing you can do to stop it is the most effective, actually. And then I think the other is being aware of if you know, like a situation is going to cause some anxiety, and we'll talk here about meds shortly, that sometimes maybe you might want to use medications to kind of help calm and help get rid of the anxiety that might be driving it. The other, like environmental accommodations that help with this approach, quiet, minimal noise. So if there are other people around, sometimes use like a code word that other people need to leave. Because sometimes the more people that are there, there's more reaction. Low lighting. And I will say this has been very interesting. In the office I formerly worked in, we had fluorescent lighting. And we had a lot more rages, a lot more upset. It was too much. Because even those lights, they have a buzz in them. And I wonder, like, how many classrooms I look at or environments that individuals have fluorescent lighting. But now in our present office that I've been in for the past 10 or 11 years, we don't have fluorescent lighting. And I think I maybe only had one or two real significant rages in my office. And I do think that lighting, we just have low-level lighting and low noise. The other is no noxious smells. You want to really minimize any type of outside stimuli that might be upsetting. I don't use candles in my office. I don't use anything that kind of adds. I used to use some scent sticks, but some patients are very, very sensitive to that. And so again, you might be aware of, are those things in your house that might be driving some of the agitation. Minimal and low volume verbalization. So sometimes very few words and lower in how you talk. I have one patient in particular who he's got autism and mood disorder and Tourette's, and he's very involved, but he can really have these. He used to have these really huge rages. He's gotten a little older. He's done quite a bit better. He's got very significant OCD, so the family follows a very firm routine. And then if he starts to, how you know with him is he starts repeating the same phrases. So the parents will say, "Yeah, I know, Joe," and then they'll just kind of. And then the other thing Dad learned to say with him is once he would rage and like he might break something or, curse, he'd say, "Okay, now, Joe, you've hurt us. Now you need to help us." So he had to engage him in a task, but it was in a very calm voice, and then he would go out and exercise can be helping calming to the brain. So he would go out and he'd walk around the yard and he'd pick up sticks. And that would help him kind of get himself calmed down, get him out of the space, but get him engaged in something else. But again, it was just with Dad. It's like, okay, you've hurt us. And it was that's part of that routine. And again, it worked very effectively with him. I think the other thing is no grabbing and no physical restraint. There are exceptions. If you're worried about your safety or someone else's safety, you may have to do that. But typically when that happens, it's going to only escalate the situation. It becomes more combative. It's much better, again, to give them space and just a presence to let them know they're not alone. Because that's the other thing. I've had times parents are like, okay, you need to go to your room, or we're leaving, and that can be very frightening because they don't know what to do. So that's the thing, too, is if you're present, it can maybe a quiet, calm presence versus one that's talking, because talking is giving more input, and you want to get things to get the brain calmed down. And that's the other thing, too, is no requirement for them to to talk, like, you need to tell me what you're thinking or look at me, because that can be very... oftentimes there's a lot of shame and a lot of, they oftentimes feel bad. But sometimes that doesn't happen right at the moment, but I think if you request, it's another demand, and what you want to do is you want to decrease demands to help the brain be more calm. I was telling someone, I have a patient once who she was in a school it was for children who had real significant emotional needs, and she needed more support than what could be offered in her local school. But this school, they used a lot of real threatening gestures, and it was awful. They had people, security officers, and that just increased all these kids' anxiety. I had so many of these kids in this school. It was not a good situation, but I know with her, they grabbed her and tried to get her into an isolation room, and in the process, they slammed a door, and it actually took the end of her finger off. And she's got for good reason, significant PTSD since then. And that's the other thing. Sometimes, too, if patients have had really bad altercations with people where they've been physically harmed or physically threatened, they can have some PTSD, and then you get the fallout when they start to rage, because that's where their brain goes back to that prior situation. Another approach that, again, it's from Ross Green. It's from a book about managing children, but it's really funny. I remember using this years ago with a child, with the parents, and the child came back the next time he came back for his visit, and he goes, "You have a book that says the explosive parent. like how do you manage the explosive parent?" And there's and again, but I look at this. I think this approach can work with any age. It's not just children. So what he has in that, and again, if you look, I recommend his book. It's maybe in the 3rd edition, but it gives what oftentimes happens with explosive children, explosive teens, explosive adults is they have certain characteristics, and a lot of the times inflexible, just real stuck thinking. There's some characteristics. Slowed processing speed. There's oftentimes they get confused. A rigid way of looking at things. I think in particular of patients who are on the spectrum. But what he says is a good approach is you put behaviors into baskets. And again, you can develop the language of basket A, basket B, and basket C. And basket A behaviors are only those behaviors where that person's safety is threatened. So I think of not wearing a seatbelt, or threatening to coming at someone to hit somebody. The language for that, for basket A behaviors, we'll talk about, it's no, stop, you can't. But those are the only basket A behaviors do you use the words no, you can't, and stop. And that takes a while of training your brain to, when your child says or your adult says, I'm going to do blah, blah, blah. No, you can't do that. Because if it's not a basket A behavior, because no, oftentimes a trigger. That's all they have to hear is no, or you can't, or we won't, and then they're off to the races. So again, you reserve those behavior, you reserve that language for basket A behaviors. Basket B behaviors are those are the behaviors you really want to focus on, where you want to help the person learn how to think and how to problem solve when they're frustrated versus reacting. And that more than often you're going to mimic, like, I know, you first of all, if like I'm going to do, or I want to do, or they indicate that they want to do something, is you acknowledge, I know you really want to do that, but I've got to do this, so let's, and you help them kind of look at another way to do it versus saying, no, we can't do that. Does that make sense? I don't know if that makes sense to you. So the first thing on that is oftentimes you parrot what they're saying to let them know you heard. That sometimes in doing that too, you give them a chance to calm down a little bit. You put a little bit of space between what their demands are. And sometimes that will help kind of de-escalate the situation. Basket C behaviors they're kind of like quirky behaviors. So they do like hand flapping when they're excited, or they want to eat breakfast food for dinner, or vice versa. It doesn't matter. I mean, those are things you can ignore, those behaviors, because they don't. It doesn't really matter. Does that make sense? You kind of pick your battles. I have another patient that I work with who's oftentimes has been very aggressive, and like with his mom, oftentimes what she'll just do is, one of her things is, no, it's breakfast time, we're not eating hot dogs. And it's like, so if he eats hot dogs for breakfast, he eats hot dogs for breakfast. Again, so it's not that big of a deal. And then, like, if she can see that he starts to get excited and it starts to come towards her, oftentimes will give him, like, something else to kind of focus on. She might come up with a rhyme or a song or something else to kind of flip his focus off of what it is that he's in pursuit of. But again, the whole thing is, if you just kind of think like, okay, in your mind start thinking like, is this basket A, basket B, or basket C? It will help you, again, sometimes to stay on shore. I think the other is to know what are triggers. And if you know those ahead of time, and if you have other people that are involved in your teen or adult's care, is to let them know what are triggers, what are things they should avoid saying. Because the biggest thing is if you can prevent an aggressive outburst, that would be ideal. The others, like I talked about before, is what are nonverbal cues. I think that's huge. I mean, oftentimes you can see, it can be, like I said, a facial grimace. It can be like an eye aversion. It can be a grunt there. But pay attention. They don't necessarily have to use words, but you can tell that there's something brewing. And if you can kind of head them off at the outset. The other is ensuring adequate rest, adequate nutrition, and a consistent routine, because fatigue, hunger, and confusion, well, they're going to lend themselves to people being frustrated and being more, again, that middle brain is not going to be calm if they're experiencing any of those. That's the others. If you're traveling with them at all, make sure you have adequate snacks so that if they're hungry, because if they're hungry or thirsty, oftentimes that's such a powerful drive, that will just really put them over the edge. So if you have something to give them to kind of console that, you can avoid having an outburst. The others, engaging them in like a repetitive or a rhyme or a phrase. Music oftentimes can help, because you want to shift the focus oftentimes off of what it is that they get locked on. You want to get them unlocked from that. But it has to occur very early in the situation. Once they're really, really upset and that middle brain is just kind of, I think of like on fire, it's going to be very hard oftentimes to kind of talk them off the ledge, if you will, and to get them calmed back down. And sometimes adding a rhyme or a music at that point is adding more stimuli, and what you want to do is decrease stimuli versus increasing it. The other thing that we look at, what are contributing factors that increase the risk of aggression. I mentioned it a little bit before, but depression or dysthymia. So patients who have, when they're depressed or they have dysthymia, is just kind of a chronic low level of irritability and mood. Although I will say I've been so impressed at the DCC patients, or DCC individuals I've seen at this conference. They seem so joyful. Now, maybe the ones who are really aggressive aren't here at the conference, or that they're happy to be here, but I've been so impressed with how joyful and happy. most of them have seen. Anxiety, excessive worry, fearfulness, panic. There can be OCD, and these are oftentimes comorbid, like conditions that exist along with the DCC. Any post-traumatic stress disorder. Sometimes that can occur even if they've had hospitalizations in the past or have had negative experiences in school or other social environments. If they have any specific phobias. I have one patient in particular who has a severe bee phobia, so getting him outdoors is like he gets incredibly anxious in the summer with going outdoors because he's afraid of bees, or if anything buzzes around him. Then autism spectrum disorders, and because there's a lot of rigid thinking, a lack of social awareness, and then these hyperfixations that can drive them, and we'll talk about that here in a minute. Certainly bipolar disorder, because of the variable emotions, there can be racing thoughts, anger. With bipolar disorder, the middle brain really has, we call the brain on fire. We really work hard on getting that fire put out with medications. Attentional or disruptive behaviors. They have people with ADD oftentimes have a low frustration tolerance. They can be very impulsive. You've got oppositionality and defiance. And any of those, again, predispose to more aggression because they're going to go against the flow versus with the flow. And any of the schizophrenic or psychotic disorders because of the paranoia, hallucination, and delusions. Oftentimes with that, there's a misinterpretation that people are out to get them, and that will increase anxiety and ragefulness. Contributing medical conditions that certainly increase risk of aggression are sleep disturbances, and I would assume those are fairly common as well with DCC. Actually, I remember learning years ago, one of the best windows to the brain and neuroorganization is sleep. The ability to be able to maintain sleep and go through typical sleep cycles and wake up feeling rested. But that's oftentimes sleep disturbances warrant evaluation and treatment because if a person's chronically fatigued, they're going to be more irritable and more at risk for aggression. Diabetes, certainly variable blood sugars increase irritability. I've had another patient who had we didn't know it, but he would have these huge outbursts, and was diagnosed with diabetes, and so his blood sugars the variability of those would really throw him into kind of a tailspin with real significant aggressive outbursts. Seizure disorders, because some seizures can present as aggression. There are temporal lobe seizures that can oftentimes just present as being really aggressive. The other is medications used to treat seizure disorder oftentimes can cause fatigue, irritability, mental slowing, so cognitive slowing, and then with that, then there's frustration because they're, and the other is I know with, I have some patients that on Depakote that have high ammonia levels, and that just causes further irritability and fatigue. So again, it's the medications as well as the disorder itself that can cause, increases the risk of aggression. Migraines, again, fairly common comorbidity, but again, there's much lower threshold for stimulation, and so can get more easily upset. I notice I pay close attention. I have a window that faces the west, so I get a lot of bright afternoon sun, and I just tend to pay attention when patients come in. If there's like squinting or I just lower and shut the blinds so that there's less stimulation. Any sensory processing disorders, because again, think of like sensitivity to light, sensitivity to sound, smell, touch. And sometimes those things that we just have to, you just do an assessment of the environment and what are things that might be contributing to getting that middle brain more upset. Hypertension, and people who had, a person recently was experiencing more irritability, especially as the day wore on, and I'm like, you know what, have we checked blood pressure? Because high blood pressure, and it's not common, but some of the medications that people are on, or sometimes there can be a family history that they can have hypertension even at younger ages, even if they're have a good BMI, that they're not overweight, they can still have high blood pressure. So I always think it's a good idea to have blood pressure checked on a regular basis. Chronic pain, so anyone that's got any chronic pain syndromes, because that, again, low threshold for stress and irritability. And then if there's any dementia, there's more confusion, more anxiety, and less ability to tolerate change in life. Supplements that can help, that I oftentimes have patients, I recommend L-theanine. I don't know if any of you have heard of that. It's a green tea extract. It has calming. It helps with calming and helps with focus. It doesn't have to be taken on a regular basis. It can be taken as needed. It's interesting because I've recommended it to some of my teens and young adults. I had one person in particular before he was getting ready to go live in a group home. He would have these afternoon upsets, and we used Ativan. I'll talk about that shortly, but we used a prescription medicine, but we really didn't want to have to use that consistently, and we used L-theanine, and then actually it was interesting because then the whole family started taking it. They came in the evenings and like, okay, and then they all felt they were more calm, and that this young man has certainly been more calm, and that's kind of been his mainstay. He gets it every afternoon at the end of the day. It comes in, like typical doses are 150 to 200 milligrams. You can get it at like a health food store or off of Amazon. It's pretty well available. Sometimes it's combined with valerian, but the valerian will make them sleepy. So typically I recommend for the anxiety and calming effect just the straight L-theanine. If it doesn't work, either it doesn't work, or if they seem like they're more irritable, then I'd quit using it. But it gets in, it doesn't have to build up, it works pretty quick, within like 30 to 45 minutes. Ashwagandha is a newer one that I've recommended. It's an herb from an evergreen shrub, but it also helps decrease inflammation and stress. Typical dose is 600 milligrams. People use higher doses to facilitate sleep, but I've had more patients that use the lower dose, and it's just kind of helped them. There's been more calmness. In particular, I've had a couple patients with school anxiety or school phobia, and they just take that. Actually tend to take it in the evening, and it still the effects persist in the morning, so there's been less anxiety about going to school. The other, and I mentioned this yesterday, but is add vitamin D3. Anyone I screen, now maybe if you live in a state that's got a lot of sunshine and you're teen or adults outdoors a lot, you're fine, but most people that I screen at any rate are deficient in vitamin D. I live in Indiana, and we have a lot of cloudy days. But you have to consume enough vitamin D-rich foods and then be outdoors in the sunshine. And people with low vitamin D levels are more prone to depression, irritability, and fatigue. And I've seen it make a big difference in my patients. It's funny because I'll have patients and they're fine, and then parents are like, I don't know, they've been more cranky lately. I don't know what the deal is, blah, blah, blah. And then I go back through their list, and they'd quit. They didn't know if the vitamin D was doing much, and they quit giving it. And it certainly did make. The one I didn't put on here that we talked a little bit about yesterday is B6. Vitamin B6 can also decrease irritability. So often is a good supplement for patients to take as well. And then we look at medications. My slide kind of moved it over, but medications that can help decrease the frequency and intensity of aggression. And again, if your loved ones might already be on a lot of medications and you don't want to add one more, and I certainly understand that. But these are some of the medications that oftentimes are very effective. The alpha-2 agonists, they're actually used, they can be used at higher doses to decrease blood pressure. So it's kind of like what they do is they put a brake on, like when the brain's kind of like that fight or flight, they kind of put a brake on it. That's how they work. They work by just calming effects on the central and peripheral nervous system. They have the guanfacine and clonidine both have an indication for ADD and tics. They help with the hyperactivity of ADD, and they decrease the motor tic movements, but they also they can have some very calming effects. Beta blockers works, again, the same thing. They're used in higher doses to control blood pressure, but they work on, they decrease the stress hormone. So that adrenaline rush that people get, they work by blocking that. And propranolol, and I have used that more often in the past several years than I did formerly. It's been very helpful in helping decrease anxiety. It's helpful. It can help prevent migraines. But again, I've found that to be helpful for decreasing aggression without causing some of the fatigue that the benzos, and I'll talk about benzos here in a minute. That's another class of medications that are used specifically for anxiety, but they can cause more mental, like fatigue, and then that increases the irritability. The beta blockers, they're not addictive. When we stop giving them, we don't ever recommend that a person come off of them abruptly because then they can get rebound high blood pressure. But they work rapidly and are very effective. I mentioned before the anti-anxiety agents, benzos. And benzodiazepines are a class of medications that they enhance GABA. And GABA is one of the most widespread chemicals in the brain that's got calming effects. So that they enhance the effects of GABA, and then they get in, when they're in the bloodstream, they work, they help calm. Now, you can have sometimes a paradoxical reaction where you expect it to calm the person down, and they have the exact opposite. And I've seen that with the benzos. You can have it with any medication, but I've probably seen it more with the benzos than I have, and with some of the other anti-anxiety agents. But the fast onset ones are Valium, diazepam, and then Transcene or clorazepate. Intermediate onset, so a little bit slower onset, but the short duration is Xanax. And we're pretty cautious about prescribing Xanax because it can be very addictive, and people can develop tolerance and they need higher doses. And then, so if I have a person and there is an extended release form, and oftentimes I will use that because it lasts across the whole course of the day. But I tend not to start with Xanax. I tend to start with Ativan or Klonopin, which are lorazepam and clonazepam. Ativan's intermediate duration, clonazepam has a long duration. Now, if you have something that's short duration, the good thing about that is if they have a bad reaction, it's not going to last very long. If you have intermediate or long duration and they have a bad reaction, it's going to take a little longer to get out of the system. But it's going to last a little longer, and which again can help, think about it calming that middle brain for a longer period of time. And then Librium we don't use very often, but it's sometimes used, and it has a longer duration. It tends to be used more with patients who are going through alcohol withdrawal. Some of the miscellaneous anxiety agents, there's Buspar, and it increases serotonin through, there are receptors that pull that into the brain cells to be used. I always laugh. The psychiatrist I work with, heard her do a speech. She talks about, it's good medicine. It doesn't have many side effects. Of course, it doesn't work. It oftentimes is pretty soft touch. So it may work for some patients, but I will say for others, it's not. It doesn't help enough to help decrease anxiety. It's one that can be used as needed. It tends to work better, though, if you give it pretty consistently and it builds up. Hydroxyzine or Vistarel or Atarax, they antagonize histamine receptors. So they're used typically, we use them for anxiety, but they're typically used for allergic reactions. But they have benefits to help people with anxiety. The downside is they can make people pretty fatigued. The other is more hydroxyzine as well as the diphenhydramine, the Benadryl. It works in a very similar way. They can both cause have a paradoxical reaction. For some patients, I don't know if you've ever had any of your loved ones that they've taken Benadryl and they get all hyped up rather than calm down. I've seen that a fair amount, so it's just something we have to look for. What was the other thing? Again, the whole thing is if it makes them tired, then it's not a very good thing to give a person if they're really agitated or so typically if I have a person that I'm aiming and want to help decrease agitation, I'm not going to use either of those first line. There was something else. We do use both the Atarax and Benadryl as a antidote if a person is on an atypical antipsychotic and they develop dystonia, any type of like abnormal mouth movements or abnormal motor movements. By blocking those histamine receptors, we get rid of that side effect. So I use it in that way. The atypical antipsychotics are, and again, people, when you think of antipsychotic, we use them more often than not for non-psychotic situations. And I really, Stephen Stahl, I don't know if you've heard of him, he's the guru in psychopharmacology. I always appreciate what he says is the medicines don't know what their names are. So we don't use them for, again, people don't have to be psychotic. They work by binding or enhancing like various dopamine and serotonin receptors. They function as mood stabilizers. Risperdal has been especially effective in helping with aggression, helping with the stuck thinking that we see in people who are on the autism spectrum. Where I worked before, we used to call it vitamin R. We always call it brain glue. It kind of helps glue thinking together. So like all these thoughts aren't out there where there's overwhelm, they can kind of help, it makes more sense of, helps their brain make more sense of things. So the atypicals and the Risperdal we can use as a PRN, so you don't have to take it every day. The other ones typically we use on a consistent basis because they have to build up in the system to be effective. But again, the other thing is some of them have indications from the FDA that we use them to enhance the effects of antidepressants. They really help decrease that rigid, stuck thinking. Like I said, we always think of it as if it just helps kind of the thinking brain. And what I look at is it helps that amygdala part of the brain, calms it back down, so then that they can go up and they can process more accurately and perceive things more accurately. The other thing is they do control psychotic symptoms, including hallucinations and paranoia. And again, the newer ones are called atypical versus the first generation of antipsychotic medications had a lot more side effects. And these atypicals, which are second generation, have many fewer side effects, and there are a whole lot more of them available than there used to be. This is the list of which ones are available. And I'm trying to think when I started working in psychiatry back in the late 90s, Risperdal, Zyprexa were about it. So since then, we've had Abilify that has come about, quetiapine, which is Seroquel, Cyprazidone or Geodon, Fanapt, iloperidone, paliperidone, which is Invega, Acenapine, Lorazepam, brexiprazole, and cariprazine. There's another one, lumapterone, it's Caplyta, and olanzapine, samidorphan, Lybalvi. Those are two of the newer ones that I've not used very much at all, to be honest with you. Probably the two primary ones that I have found to be helpful for people who have developmental disorders and aggression or are on the autism spectrum with aggression have been Risperdal and Abilify. I always dose low, go slow. Some people dose high, but the Abilify has like antagonistic properties where it can like block serotonin and dopamine, but then it's got agonistic. It lets some through if the brain picks up that it needs more of it. I always use it. It's like putting a traffic cop in the brain. So the brain kind of picks up like, oh, no, I need a little bit more of this. But if you overshoot the dose, we end up with more anxiety. So again, that's why I always tend to, it comes in like 2 milligram doses up through, I think the highest strength maybe is a 30. But probably typical doses on that are 5 milligrams, 2.5 to 5 milligrams. I have some patients who are on, I have a couple that are on 30, some that are on 15, but I tend to use lower doses and find it to be very effective. Seroquel is got very good anti-anxiety properties. It helps patients who have a hard time sleeping, so it can help with the fatigue, but they have to take it at night. There is a long-acting form, but if it's interesting. It's one that lower doses cause more fatigue. Once you saturate histamine, there's not as much fatigue. So sometimes on that one, I will go lower doses, and again, it's used more as a mood stabilizer. The paliperidone, Invega, is more like a long-acting form of Risperdal. It's a sister drug to Risperdal. So if you have a patient who's on 2 milligrams or higher, probably 1 to 2 milligrams of Risperdal or higher, oftentimes I'll switch them to Invega because it's much more even dosing. Risperdal has a very short half-life, so it's anywhere, or it varies, I guess, it can be anywhere to 3 to 20 hours. So sometimes patients use it and it wears off, before the morning's up. And anytime you have to dose meds midday. More than once or twice a day, it's harder for the compliance. But I don't know if you have any questions about any of those. You can ask me. Vraylar is one of the newer ones that it's got also antagonistic and agonistic properties. That's kind of like building a thermostat into the brain. The Rexulti has an indication and has been more helpful for people who have treatment-resistant depression. The downside of the newer ones where they're not generics is they're very expensive. The other psychotropic medications that we can consider using are like antidepressants, SSRIs like Prozac or Zoloft, or an SNRI like there's Effexor, Pristique, Cymbalta, Wellbutrin. Because sometimes if you can help the mood overall, just have the right levels of norepinephrine and serotonin in the brain, there's less irritability and less risk for aggression. If the other sleep aids, if you need a person's not getting adequate sleeps, and you can sometimes that can make all the difference in the world if you get adequate sleep, that you don't have nearly the episodes of aggression that you did before. Stimulants, if the aggression is due to just a low, poor ability to tolerate frustration, because that's one of the things with ADD is that whole executive functions. They have oftentimes problems regulating their emotions, can get upset over the smallest thing. But typically, if it's ADD driven and they're upset, they oftentimes get over it as quickly as they get into it. So more the mood driven upsets tend to last longer. And again, the contraindication to a stimulant medication, as a rule, some of the medications lower seizure thresholds. So we have to be very cautious if a patient has a seizure disorder that those can certainly stimulate seizures. Some patients, it can make mood and aggression a whole lot worse. The good thing about the stimulants is that we know pretty much right away. If you try it and they get worse, we just are like, nope, we're not going that direction. And I've had that happen to a couple patients. I'm like, well, and even like sometimes it's been years, and we're like, well, let's see if that makes a difference. And oftentimes it has not, and they just can't tolerate those. Because those stimulate receptors for dopamine and norepinephrine, which are kind of wake up. And again, can have like the opposite effect of what you want them to be doing. The other mood stabilizers are the anticonvulsants and lithium. Lithium's a gold standard for bipolar disorder. Sometimes it works. It works on cell membranes. It works on sodium-gated ion channels. So sometimes it can be helpful, just a low dose, like a 300 milligrams at night. It's even a subtherapeutic level. It can augment effects of antidepressant, but it just has some calming effects. The other medication that is Lamictal, and I don't know how many of you are familiar with it. It's lamotrigine is the generic name for it. It's an anti-seizure medicine that's got great antidepressant, anti-anxiety properties. There is a difference between the generic and the name brand. If it's interesting, in Indiana, if a patient's on Medicaid and they're on it for seizures, and the physician writes that they're name brand, and there's no prior authorization required because they've had too many breakthrough seizures when they switch to the generic. So I have a few patients who take the generic, but many more I end up doing a prior authorization because I have most patients on it not for seizures but for anxiety or depression. The other thing with it, we dose low. You have to start like 25 milligrams a day for 2 weeks, and then you go up to 50 milligrams a day for 2 weeks, and then you go to 100 milligrams. And we may go upwards to 300 milligrams a day if necessary, or 400. If you dose it start a person on it too high of a dose too fast, they have the risk of, it's called Stevens-Johnson syndrome, where they can slough their skin and slough their nails, and it can be very serious, it can be fatal. But again, we just tell people, like, if they miss a dose, don't give an extra dose. And once they get past that 6-week period, they don't have that risk. There's a greater risk of having the Stevens-Johnson from an antibiotic, but it's just not a common side effect that we see with psychotropic medications. But it's been very effective. It also, the thing is, it comes in even like if people are tinier and they're real sensitive to meds, they're like a 5 or 10 milligram dose that they can take as well. And there's a chewable form if they have, because the regular tablets are kind of chalky and don't taste the best. But it's been a very helpful. Then one of the other things we like about it is it doesn't cause weight gain, and it doesn't cause mental fogginess. This is another quote from Ross Greene that I always like, and I think about, children do well if they can. If they can't, it's our job as adults to figure out why and offer help. And I think the same thing's true as parents do well if they can, teachers do well if they can, and the professionals do well if they can. And if they're not doing well, then we need maybe it's an education. We need, to put efforts into helping them learn and, be patient with one another. And I don't know now if I wanted to leave extra time if people have specific questions or situations about aggression. So I don't know if anyone has anything else that they have questions or thing they want to add. Yeah. Mm-hmm. 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 They can take those supplements with those. There's not a contraindication. Mm-hmm. Yes, exactly. I know. That's what I said, that my dream would be if they could come up with like a patch that they could just put all these meds on a patch and, put it on and then it could get absorbed. But we have a couple medicines that are transdermal. But so many patients react to the glue and they get allergic reactions. And so I don't use transdermal very often. Yes? Mm-hmm.
On the same subject, you mentioned some foods are high in D3. What might those be?
More milk-based products, cheese, milk, yogurt, ice cream. Yeah. Mm-hmm. Yeah. Mm-hmm. Okay, we'll say that. Mm-hmm. I have a question. If it works, if the melatonin works and there's no adverse effects, there's no like rebound or like sometimes too much melatonin, they can have headaches the next day or be more fatigued. Sometimes supplementing it with valerian, there's some with valerian, but the other is sometimes if they don't, I don't, do they not hit the deep stages of sleep? Mm-hmm. Right. I have a question. Do you have access to getting a sleep study? Because that's the thing too. Right. Because I think of when I think of melatonin, it helps more with again those receptors to help people fall asleep, not as much stay asleep. There's a prescription medicine. Oh my gosh, why am I blanking on it? But it stimulates the orexin in the brain, the orexin receptors in the brain, so it decreases the wakefulness. It's Balsamra. That's been very effective. I like it because it just works on those orexin receptors, so it's pretty unique. It's not like Ambien or Lunesta, because sometimes they can have some pretty weird side effects in the night. Now, I have some patients that take those, but I don't know, like with Ambien, sometimes they have like middle of the night wakenings to get up and they eat or they do things they don't even know they're up. They have no recollection of being awake. So I'm not real cracked about that. But for whatever reason, it seems like the Balsamra, there's more restful sleep. Yes, Belsomra. Oh, you're welcome. Yeah. Mm-hmm. I think it's worth trying. It's not necessarily, because sometimes because the Abilify has agonistic as well as, so I always think of like when it's agonistic, it's putting a brake on. No, it's putting accelerator on. Agonistic is putting the brake on. And so Abilify has both of those, whereas Risperdal just has the braking part. That's why I think the Abilify works well, like that you can use as needed if for like just acute upsets or periods where there's just this real stuck thinking and you need to be able to move on. You can do that with risperidol, yeah. Abilify, it takes a little longer. I don't tend to use that as a PRN as much because as a rule it has to build up in the system, and because of the agonistic, it can sometimes cause more irritability. Although I have to tell you a funny story. I have a patient once, he was on Abilify, and the mom came to and she goes, "Can you prescribe this for my dog? He ate half a pill and it's the best he's ever slept through the night." I said no, but thanks for asking. Yeah. Oh, you know the dystonia symptoms? Yeah, the tardive dyskinesia, correct. I mean, there's certainly that risk is present with all of the atypicals, and it tends to be dose dependent in terms of, I have one patient who's had, no, I've had two patients who developed that side effect of tardive dyskinesia that hasn't gone away with taking them off the medication. And the one, it was from Abilify, but he's on this it's interesting because that tends to happen if they have more comorbidities or if they have an underlying brain. And this is he's now a young adult, and he's got CP, cerebral palsy. So he's on this medication. The risk of developing permanent movement disorders is fairly low, especially if it's picked up early and you take them off the medication, the offending agent. Or if you lower the dose, if they need a higher dose, we use first line. We'll use Benadryl or Atarax. Then there's Cogentin, which is used for people who have Parkinson's. I have maybe a couple patients on that, but it causes them to be tired and it can cause some cognitive dulling. And then I'm like, okay, here we have a medicine and we're adding another medicine. And so I don't like that if I can get away from it. But what I did. For this one patient, it's this medication called Austedo. It's Austedo. It's been like a miracle for this patient because, well, first it's very expensive, but we have a couple pharmacies, Genoa pharmacies, and I sent a prior authorization, and it covers it, and the family doesn't. He's on Medicaid, but I don't even think the family's had to have a copay. But his speech has become more fluent. And they said I asked our drug rep if they were doing any research on its use with people with cerebral palsy in the motor. Because think about it, I mean, cerebral palsy is a movement disorder. But I was just so impressed because I followed him for years, and then he was on this Austedo, and it stopped his movement. He doesn't have those movements anymore. And his speech, he's fluent. It used to be his thought was hesitation, and he would have a hard time finishing a sentence, and now it's just fluent. It comes out, and that's the only thing that we changed. So I think the Austedo's had some positive impact on that. So I'm curious. What's that? It's used for movement disorders like tardive dyskinesia. Yeah, and there's another one in that class, and I've never used the other one. They're very, very expensive, but again, I've just been so impressed with how it's got rid of his movements. And again, I think he was higher risk for the permanency because he always had already had an underlying movement disorder with the cerebral palsy. But the risk with the other meds, again, I've treated for a lot of years, and I've not had any, like I said, two patients who it's been. And the other one is the one who's got the comorbidities with Tourette's. And sometimes it's hard to sort out what's his Tourette's and what's a movement disorder for the medicines. But he's able to work and function so much better with the medicines, so we haven't really... I back down. It's interesting because kids and teens oftentimes need higher doses of meds because of just differences in their metabolism. But the other is I look at kids and teens when they're in school, their environments change so much. And as they get a little older, if they can get a consistent environment, their brain stops changing so much, then oftentimes I can lower and they're not on as many meds. Mm-hmm. Uh-huh. Mm-hmm. Okay, that's a pretty low dose. Yeah. Okay, well, again, it just depends on the person because if they're tolerating it, But I would say anything like 4 to 5 milligrams or above. And that's where I would look at, oh, maybe the Invega, but if he's doing well on the 2.5, I wouldn't change it. I don't change anything. I don't fix something if it's not broken. Yeah. Mm-hmm. Yeah. Mm-hmm. I'll go back to the lumaptaprone, the Caplyta. It has an indication more for mania. It helps more the high mood symptoms. You know what? I don't have it in a chart here, but they're similar, but they hit receptors different. Like some hit more like 5-HT3, and some hit 5-HT2, and some hit like D2. I mean, they're different receptors, and I don't have that chart here in front of me to know the exact difference, but they're in the same class, so they have similar. And oftentimes, I've had patients, I've tried on most of these. The Olanza, the Lybalvi is a newer one. It's like the olanzapine Zyprexa with the samidorphan to help with mood stability. And you can use a lower dose. It requires less of a dose of the olanzapine, and with the samidorphan, there's less weight gain risk. I've used it in only one patient so far because it's, again, relatively new, and it just made him too tired to function, so I haven't continued to use it. But they're similar. Lorazepam can be very helpful with depression, and it can oftentimes, they take it at night, it helps with sleep. And I don't think it causes as much tiredness as the Seroquel does the next day. The Lorazedone's getting ready to go generic. Acenapine is already generic. Are any of you familiar with acenapine? It's Saffris. I don't have a lot of patients on it because it's a dissolvable tablet. They have to put it under their tongue. It's like wild cherry or black cherry flavored, but it makes their tongue numb for like 30 minutes after. And don't have many, and I've heard even if it's black cherry tasting, they said it tastes awful. So I don't have many patients that can tolerate it. I might have just a couple patients. Yeah, especially with the sensory issues. So any patients who have sensory issues are not going to tolerate that. But I guess when it works, it works. It's the good thing about it is they can't cheek it and spit it out. Because sometimes, that's the other thing. I've had patients that think they're taking their medicine, and then the dad goes to cut the grass, and he finds all these pills by the tree out front. I had another patient. We had tried on so many meds, and I don't remember what happened. And the parents called me like, we just found all these pills in the register, because he would, at the table, his chair was above the register, and he'd take the pills and just drop them down the register. So I'm like, well, yeah, they don't work in the register very good. Yeah. Mm-hmm. Okay. Mm-hmm. 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 Right. Mm-hmm. 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 Uh-huh. Risperidol's more, it's in the same class as the Abilify, so it's going to work more, but more blocking like dopamine and serotonin receptors. And again, right. Right. Well, to me, again, in my experience, Risperidol helps more with the stuck thinking, but the alprazolam helps with anxiety. It has calming effects. So, but I would optimize his Abilify dose. If I don't know if he needs a higher dose of that, or could try. Oh, he's not on. He's on. What's you Seroquel? Sertraline. Okay. Oh, okay. I don't know. I would think an atypical might be more favorable over. Okay. So maybe the risperidone would be worth a try. I sometimes go through like, okay, well, they didn't do well. The other is that I talked a little bit, and I don't have it on this talk, but there's a gene testing you can do. You swab inside their cheeks, and you send it into gene site, and then they can tell you like what medicines your child is going to most likely be better likely to respond to and have fewer side effects, or how do you need to adjust dosing. Okay, yeah, it can be very helpful. Because I've had patients who I'm like, I've tried medicines, and then because it puts medicines in like a green column, and then a yellow means they're intermediate, and a red means they're a poor metabolizer. And the ones they all have a footnote, like if it's in the red, like it says a poor metabolizer would need higher risk for side effects, needs lower doses. So again, I always think that's very helpful because sometimes before we had that testing, I have patients, and I'm like, usually I'm thinking I always wanted to pride myself, like I'm going to get their meds right the first time. Well, that has helped me because I'm like, well, we can use medicines in the red column, but I'm going to follow their recommendations and use either lower or higher doses depending on what that gene site testing tells me. Gene site metabolizes it based on their genes. Correct. Mm-hmm. Yeah. Mm-hmm. Yes. Yeah. Less guesswork. Mm-hmm. Right. You could use a breakthrough, or if it's if daily rigid thinking gets in the way, to take it every day. Yeah, yeah, you're welcome. You had a question? Yeah. Uh-huh. Right. Well, I would recommend that, kind of like you do like an IEP in the school, that you have a plan, that you meet with the staff to say that he's got his own plan. This is how, these are things that cause him to escalate. This is they need to, anyone that interacts with him needs to know what will work to help him calm down and how to prevent. And actually I know that Deb Lipsky, what she recommended, like this, and they have like plastic, like sometimes she recommends wearing something like this, a lanyard that's got very clear like what things to put on there to do, to not do, don't do, or but very little verbiage, but that it's not there because once the person's upset they can't use their language. But I would say anyone that interacts with him needs to know the sensory stuff, needs to know again what things to avoid and what things to do to help him calm down, because that's what you look at too. It's they're capable. And when a person when they're aggressive or they have issues with aggression, they need help, they need support, and they don't have it internally. They really rely on the external world to help around them, their environment, to help them be able to function, and that's what he needs. You know, I look at, do they are they aware of the risk? Because if something happened to your child, I mean, they're going to be liable for any injury or. Have you approached it with like, okay, we want this to be successful for him and for your staff to feel competent and comfortable, and here, I don't know, try approaching that way to say, hey, this is what's going to work. And, and it's, it's got to be so frustrating. I don't know, I agree with Dana, you don't have a behavioral therapist that's involved. You know what, before you leave, Shannon wants you to know that at what time, 6 o'clock? Any parents or care providers, if you could. Great. Thank you. Thank you. Well, you're welcome. Hey, I got you out of here early.